I'm going to. Hello, everyone, and welcome to a masterclass. Another one. Today, I'm super happy to introduce Alyson McGregor to you. She is Associate Dean and Professor of Emergency Medicine at the University of South Carolina School of Medicine, Greenville. Alyson is really a spokesperson and advocate for women around the world. She is the co-chair of the National Sex and Gender Education Health Summit. She is the co-founder and past vice chair of the national organization Sex and Gender Women's Health Collaborative. And she is the author of a wonderful book that was published in 2020. It's called Sex Matters. And it is in the meantime, it is available in 5 or 6 other countries beside the US. She also has given a TED talk about why medicine often has dangerous side effects for women. And this TED talk was watched more than 1.7 million times. And it's really amazing that we have one of our role models tonight here. And I welcome Alyson McGregor. And Alyson, the floor is yours. Thank you very, very much. Alyson, you can start. And as usual, for those who have been here before, Alyson will give a talk, 30-40 minutes. Feel free to ask your questions. Andrea, the co-host, will collect the questions, and afterwards we'll share and discuss with Alyson. Alyson, the floor is yours. Thank you very much.
Thank you so much. And I'm honored to be a part of Role Model Rebels. I think that organizations like this are so critical to empower women in so many facets of business and health and technology. So I think it's just wonderful. I'm happy to contribute. So just so you understand, my perspective is coming as an emergency medicine doctor. So I have practiced in a level 1 trauma center for about 18 years. Does it seem like that much? And so what that has afforded me is this opportunity to see so much about health and sickness of the human condition, because if it's even possible to happen in the world, then it ends up in the emergency department at some point in time. So I've had this really broad perspective and this really sort of unique way to see what our problems are, what our gaps in our healthcare. And so that's what I started to really look into. So in order to I'm going to take you on a ride so you understand sort of the historical perspective of how we arrived where we are today. And so we were always taught that men and women were the same except for their reproductive organs, right? So a sperm and an egg get together and they'll determine what sex chromosomes you have, and then that will determine if you get ovaries or testes, and that will regulate your hormones, and the hormones will give you secondary sex characteristics like hair and breasts, development, and that sort of thing. And other than that, we were identical. And so the truth is, when I'm, seeing these patients, that men and women are not the same when it comes to health and disease. 78% of all autoimmune conditions occur in women. Sudden cardiac death during exercise is like 60 times more common in men than in women. We know that women suffer from migraines and irritable bowel syndromes. We also know that cardiomyopathy, the way that the heart deals with high blood pressure, the mechanisms of even that specific of a condition are different between men and women. So even when a condition occurs in both men and women, someone seems to have a greater incidence or a greater severity than the other. And so when we started noticing this, we started realizing, why isn't this taken into account? So human subject research has really evolved, and thankfully so, but there's an issue with it. So this is a grim photo because it started off very grim. We would do experiments on enslaved individuals. World War II, Dr. Sims, who established, he was the godfather of gynecology. He performed his fistula surgeries on enslaved women. So there was a lot of history where this needs to be changed. So we need human subject protection. So in the United States in 1973, the National Research Act was enacted, and that's what it was designed to do, to protect human subjects, to undergo institutional review boards, to have informed consent. All of this was really wonderful, except what they also did at that time was they labeled women just as a population as a protected subject, because they thought, well, what if the female or the woman gets pregnant during the study? So let's just, and men and women are the same in all other ways anyway. So let's just remove women from the pipeline and we'll protect them. This also came to feel like researchers were embracing this because it's easier to study just men because they don't have the constantly fluctuating hormone levels that women do. So they're less variable. In order to enroll lots of women into the study, you may have to increase the power of the study to make sure that there are, we're taking into account the different stages of the menstrual cycle. So this was just deemed okay scientifically and more convenient. So the result is, and this is, I love these two slides, was that what we have done is we have understood all of our clinical trials since then: cardiovascular disease, stroke, and cancer and infections. We learned all of that in men. And then the one thing we couldn't study in men was breast health or having a baby or the menstrual cycle. So then we studied those things in women. And what happened is it trapped all the effort into providing medical care for women into just those issues. So many women think that their biggest health concern is still breast cancer, when cardiovascular disease is the major cause of death for women. And so we sort of reduced women's health into just reproductive health. And so why was that such a big deal? Ambien is a great example, and it's the flagship for this because Ambien is a sleep aid, and it was initially studied in men, mostly white men, and but mostly prescribed to women for 20 plus years, because women are more likely to get diagnosed with sleep disorders than men. So we're prescribing this based on the studies that were performed on men. And then all of a sudden, there's enough post-market surveillance, which really is all you get for women. In other words, once a study drug passes through all of the processes and gets approved and then is now able to be prescribed to the population at large, post-market surveillance are when people can say, well, I think that there was a problem and I think it's related to this drug. And so what happened was there were all these reports of women waking up the morning after taking this drug with impairment. So they were still sleepy. And what they were doing was they were getting into their cars and having impaired driving. Now, as an emergency medicine physician, again, impaired driving is a serious issue. A motor vehicle crash is life or death. And for it to be, substantial enough to have someone stop what they're doing and write a report, these are serious issues. And so what happened was the drug company looked at this and discovered that women metabolize the drug at 2 times a slower rate than men. So we were being prescribed the same dose as men and then having twice as much of the drug still in our system the next morning. So the FDA in the US decided to have the first sex-specific dosing regimen for men and women. So men receive 10 milligrams, women receive 5 milligrams. This is one drug. Now we have to think about the millions of drugs that are, throughout our global world use, and think about, well, who were they studied on, and what's the consequences of not studying this in women? So the NIH, which is our major funding body, have said that yes, we should start enrolling women. And we should also make sure that we're enrolling women and females at preclinical stages, so cells and animals, because what we want to know is what are the mechanisms for these differences. And so they really sort of said, okay, let's make sure that you have to include sex as a biological variable if we're going to fund your study. But what's really fascinating now is that we're even asking for more than that. So it's not just about including women into a study and including men into a study. I'm going to demonstrate for you where we are to this day. So this is an example of a study of a drug called naloxone. So it's high dose naloxone, naltrexone. So it's the same thing as Narcan for opiate not withdrawal, for opiate overdose. But it's a pill form and it lasts a long time. So this researcher said, well, what if I give this medication to men and women who have cocaine disorders? Maybe it will help them from doing less cocaine. So they first gave it to both men, males and females, and as a placebo. So they gave them a placebo. And then the time frame on the bottom, the x-axis, is how long the weeks were. And then the y-axis is the amount of cocaine that they reportedly used. So the placebo, men and women, did about the same amount of cocaine and over time. So then the study said, okay, well, let's give the study drug to men, and men actually did less cocaine on the study drug than when they were on placebo. And when they gave the drug to women, women actually did more cocaine than when they were on the placebo. And so what this is demonstrating is that we can't just combine the results. You can't just have 50 women and 50 men in a study and then combine them, because we might, hide the results. This would have looked like there was no difference between men or women. And instead, we're missing a chance for a thing that might be helpful for men and might be harmful for women. So this is why it's so important to think of us as having different physiology and different mechanisms. Our Food and Drug Administration said, well, okay, let's just, we don't have the ability to make pharmaceutical companies do sex-specific analysis, so we'll just be transparent. And they just developed a drug trial snapshots. And what this does, it actually says, okay, the drug that was just recently approved, we're going to show you on, you can just go to our website and you can see who was enrolled based on age, sex, and race. And these are some examples of how it shows. So if you're drug A and you're like, oh, I was just prescribed drug A, well, there's 88% women in there. That's should be good, right? And then if you're drug B, it's like 50%. Well, isn't that okay? Or the opposite effect with having only 26% women. And what I'm doing is demonstrating that this isn't enough. There's not enough information. I don't know whether it was analyzed to determine if sex differences exist. So although we're starting to get at sort of a transparency issue, we definitely need more a push for regulation in how these studies are performed, because this is the future of science. Once we discover there's a sex difference, okay, there's a sex difference in Ambien, right? Well, let's make sure that we give the correct dose. But when I think about this as a researcher, I think, well, what is the source of that sex difference? Because that's what's going to lead to greater scientific understanding. We haven't realized that there's all this amazing undiscovered information. And so what we look at is, what are some of the sources? Well, the source could be biological sex, like I mentioned, what your sex chromosomes you have, XX versus XY. Why is that important? Because we thought that they just became dormant after they assigned you ovaries or testes, right? But that particular sex chromosome pair is in every cell in the body. So it's in the heart. It's actually makes a different way of conducting heart disease between men and women. It's in the liver. It's there are now over 1,000 genes discovered in animal models that show sexual dimorphism between men and women. What that means is differences, so different expression of enzymes. So that's why these drugs may be metabolized differently. These chromosomes are in the kidneys. They affect excretion. They're in the lungs. They affect your ability to be susceptible to COVID. They're in your brain. They're in your intestines and lining and everywhere. And so they're doing things. They're involved. Is the sex difference due to hormone levels? Because we really haven't studied them to any specific degree. Women have fluctuating hormone levels throughout the month and throughout the lifetime. So do men. Men have testosterone levels change throughout the lifetime. If you look at the 20, 30, and 40-year-old males represented here, this has been our subjects of research. Our understanding of most medical knowledge to this day have been from that cohort. And so, but now we know that hormones affect the ability to metabolize drugs, the ability to, your body fat distribution changes, your susceptibility to infections changes, all based on hormone levels that we really haven't taken into account. For instance, drugs for seizures. So they're called anti-epileptic drugs. This is an example of one of the drugs. So these are the drugs that for seizure. And then this looked at whether someone was also taking birth control pills. So some sort of hormonal birth control pill. And so I've underlined two examples here. The first one is lamotrigine. And what it's demonstrating is that if a woman is prescribed and taking this drug to prevent her seizures, and then she's on birth control, that she has now decreased the effect of that lamotrigine by half. So she's more likely to now have breakthrough seizures. And so, without any sort of titration or change in that drug dose. The opposite could happen with the other drug, oxcarbazepine, which means that if I'm prescribed that drug, then my birth control decreases by half. And that's a big consequence. I mean, maybe an unwanted pregnancy. I've seen so many complications related to some of this stuff, and we're not taking this to account as a society. This is one example from 2012, yet is really not utilized, is, okay, here's an algorithm for this seizure drug around pregnancy, where it's talking about, are you on oral contraceptions? Maybe you should reduce your level or your dosing to this, and then afterwards you should maybe increase it to this. Like, we should be having this types of algorithms and medical care for women as a routine understanding of how these things affect their health, and they're not. Was the difference related to the environment? So gender differences in health, or race, or your weight, or age, or sexual orientation. All of these things affect your health as well. For instance, the example I like to give are women who live in a society that they wear a burqa, so they cover their skin. Just that social norm for that culture and gender alone can protect against skin cancer, right? So skin cancer rates are lower for those women, but their vitamin D levels are lower because they're not getting, as much sun. So these are things that we now have to start to look at, because maybe it's due to something in the environment. What I like to also take into account is that if you are one sex and a different gender, if it's not congruent, then when we're studying what the causes of these things are, and we say, okay, well, this is a specific sex difference and this is a specific gender difference, that we can take the right evidence from both, and we can personalize it to the individuals. And this just also demonstrates how important it is to understand hormones as far as effects on our body. So this was a group of pharmacists who got together and they said, well, what about if you're transgender and you're taking gender conforming hormones? So if you're on testosterone or if you're on estrogen, what does that do to your kidney function and your drug metabolism? And they found that if you were taking either estrogen or testosterone to transform into a different gender, that your renal clearance of drugs changed to that of the gender that you are changing into. So their call was, we should be including this into our understanding of your electronic health record. We should say, are you on hormones? Because maybe, and how long have you been on them? Because maybe we need to have dosing changes based on this. So I find this new understanding really conceptually interesting. Is the difference related to your environment, anthropometry? Who designed my chair? Who designed my table? Because that affects my health. And one of the most striking examples is crash test dummy bias. So after 4 decades of using crash test dummies, we still do not have an adult female crash test dummy that's routinely used in these testings. What happens? Car manufacturers will design their cars to pass that test, and that test is biased because it is being perfected based on a male model. And so what happens that if a woman is sitting in the front seat, either a driver or a passenger, she is 22% more likely to have head trauma in an accident than men. She's 44% more likely to have neck trauma than men. She's 38 times more likely to have abdominal trauma. She is 73% more likely to be seriously injured or 17% more likely to be killed. Women are generally shorter. They like to sit closer up to the dashboard. We have wider pelvic girdles. Men have stronger neck muscles. None of this is involved in our design of safety. And so maybe when we look at data of why do women more likely to be killed when they're sitting in the front seat, these are important things. And the last one is the observer interaction. And this one is becoming more and more interesting and studied. Maybe the gender of the researcher affects the result. And they've shown this in animal studies. It's called the male observer effect. So when a research assistant was a male, the mice acted differently than when it was a female. And it's because they can smell the pheromones, right? And so we haven't considered anything like that. The gender of our physician affects our health. We now know that in lots of literature, the gender of the physician matters in surgery and taking care of your heart attack and whether or not your pain is managed. And so this is really the exciting part. Like, when we start to find a difference, then we look at the source. This is what has been missing, I believe. It's going to lead to actually reproducible science, because most of the social science and medical sciences, only 40% are considered reproducible. Well, it's because we haven't taken into this account, and it's responsible science because women make up more than half the population. So not understanding all of those levels, what has happened, what was the consequence? Doctors think they're practicing evidence-based medicine, right? Everyone's giving lectures on it. They're looking at the literature, but what is evidence-based medicine when it's based on, when the cell-based research is still 76%? No idea what the sex of the cell is that they're studying, never mind how it affects the outcomes in the analysis. 80% of animal models are still male. Yes, we are enrolling more women into clinical trials of humans, but like I mentioned before, it's not just about throwing some women in a clinical trial. Women are the healthcare deciders for the family. So how generalizable is this for me as a physician when I see patients in the emergency department? And maybe it's one of the reasons why something like cardiovascular disease, women still have higher mortality rates than men. So when you think about that and you look at that statistic and you start to think of why, maybe it's because I was taught that this is what a heart attack looks like, that you're a white man and you clutching your chest and you're thinking that you have an elephant sitting on your chest. Okay, that's what I was still taught. This was a study group to help medical students pass their boards, and I was able to look at their materials, and this is still being taught today. So this is what they are teaching as how a heart attack looks like. Again, the same white male, balding, diaphoretic, which means sweating. He's got crushing chest pain. This is what a heart attack looks like when you are a woman. You might feel like you're just tired, unusually tired. You're nauseous. You're dizzy. Doctors have not been taught that this could be a sign of a heart attack. Paramedics have not been taught that this is a sign. The public has not been taught that this is a sign. So that is major, right? We have to think about that, and this extends to even the pathophysiology of that. So what's a consequence? This is what a patient example I'm going to provide. So this is a woman, she's probably 45 years old. She's at work and she starts getting this funny feeling in her chest, and she hasn't been feeling well lately. So her colleagues say, you should go to the emergency department. You don't look good. And she's like, well, I've got all these deadlines, and all right, I'll go. So she goes to the emergency department, and she has to wait a little bit, but then she starts getting anxious because now she's like, God, this like, it's very uncomfortable in here. There's all these fluorescent lights. I'm missing work. So the doctor sees her and says, you look anxious. Yeah, I am. Well, okay, well, here's some Valium. So here's some Valium, make you feel better. It's like you had a glass of wine. And now the woman's like, oh, I don't care about those deadlines anymore, but my chest discomfort is still there. And so the doctor says, well, it looks like here that you have reflux disease and you take Zantac sometimes. So this is probably your reflux. So here's some lidocaine and Maalox. She takes that. And then it's still painful. Well, when I press it, it hurts. And it's probably costochondritis. It's musculoskeletal. Here's some ibuprofen. And so she takes the ibuprofen, and then now she's like, it's getting worse, actually. So the doctor's like, well, okay, let me do an EKG and kind of look at some blood work. In the meantime, here's some morphine, without realizing that women have higher instances of nausea and vomiting and respiratory depression on morphine. So now she has to be put on the monitor, and she starts vomiting. So she needs some medication for vomiting, and stuff starts coming back. And then the doctor thinks, well, maybe I should give her a nitroglycerin because now things are looking like this could be her heart. None of these drugs were tested together, never mind originally even tested in women. And what happens is, this is how women in the world are feeling today. They are feeling as though they're told that this is just in their head, that it could be their anxiety, it could be their period. We're just don't understand women from the same extent from their health and well-being that we do for men. So we're just seeing what sticks, and that's not okay. And again, this is from the Netherlands. Treat me like a lady. Healthcare is based on the male body. So I just want to show that this is a kind of, the world is really waking up to this right now. And so what else is missing? There's bias in the entire system. There's bias in your smartphone. If you ask your smartphone for help, it depends on who wrote the algorithm. And so if we don't have a lot of women in STEM fields, then those algorithm writers are mostly males, and they're going to write those algorithms based on their perceptions. Maybe, like I said, the textbooks, maybe the reference ranges for the blood tests, for all of the educational materials that are still being used. If they weren't written with the concept of women, then they're biased too. For instance, medical textbooks still overwhelmingly use pictures of young white men. And so how does that prepare our future doctors to take care of anyone other than that? Because that is constantly the pattern that we're taught to recognize. Are we adapting this kind of new understanding of the importance of sex and gender in real time? COVID is a great example of that. That would have been the classic time to really take a look at this. It was also the first time that really demonstrated that men have higher mortality rates when having COVID. So I was really thrilled thinking that this demonstrates that understanding sex and gender is not just about women's health. We have a lot of catching up to do for women, so that's huge. But just having this understanding will help, understand our science and our research for both men and women. But then I look at the trials for the drugs, and this is a review that looks at it. Out of all antiviral agents, remdesivir, you've heard of this thing, hydroxychloroquine or convalescent plasma. If we look at all of the studies, a quarter of them had double the men, and then only one post hoc did a sex-specific analysis. So just like with the high-dose naltrexone, only one went back and said, "Well, what if we analyzed it separately?" And then 0 of them looked at sex as a modifier. So now, should I understand that remdesivir might be helpful to me as a woman, maybe at that dose? It's hard to say, right? It's this lack of appreciating the importance of this for women. And how do we evolve? So we need to have a double edge advocacy. So what we do know is that when women think of women, right? So this particular study is amazing, and they looked at 1.5 million research papers. And when the primary author, which is the first or the last name, was a female, that study was more likely to enroll women and to analyze the data based on sex. So that just tells you that if we get more women into these, research positions and support their development in science, we're more likely to have more information about women. When the editors of medical textbooks were women, they were more likely to have pictures of women. And so again, it's this concept of making sure that we have diversity and that we empower women. And to also think about language. Let's make sure that we continue to evolve in the way that we discuss these issues. So for so long, men were considered typical. And so the way that men have heart disease is very typical. And the way that women present was considered atypical from that. But I say that is false, and it perpetuates this bias, right? Women are not a subgroup of men. We are our own institution that needs to be studied and embraced. And so when you look at it through the scientific lens of this, we should be saying, okay, what's typical for men and what's typical for women, and to save atypical for any sort of extensions outside of that. So I think it's, these are the small things in our conversations that we need to make sure that we understand. I think that in general, those who go into science and those who go into medicine have this understanding that this evolves. So it's the way that I was taught to practice medicine when I first graduated is very different from the way I practice now. When you look at surgery, this was how it was done. It was in a theater, all by white men, all wearing suits, no anesthesia. We've definitely evolved, and I think that this is something that scientists and doctors can embrace. And so thank you for mentioning my book, Sex Matters. What I really try to do with this is ensure that I've had all of this work in research. I've published, a lot of research. I've worked the past, 8 years or so trying to get medical education to include all of this updated research so that we can have this clinical practice be affected. But then I would show up for my shift at 3 p.m. and nothing would change, and I would see these women come in, and again I just felt like something needed to change. So I wrote this book to make sure that there was this grassroots understanding that I'm empowering women to advocate for themselves in the broken system as it exists. So that way we can have top down, bottom up, really just as many ways for women to advocate for this change, I think is important. And I do that by, discussing these things, which are making sure that women really take control of their personal medical record, right? So if you have anxiety listed in your medical record, like make sure that that's something that you agree with. Make sure that you do your own research. Go ahead and go onto Dr. Google and inform yourself, and then come with specific questions, right? She said, I just looked this up, and I feel like this pain could be this, or and ask them why not, or what they think is happening. One thing that I think is really critical, especially for women, is to bring an advocate, and make sure that you be an advocate for other women. So a lot of women, especially if they're in pain or if they're, uncomfortable, they, can often be dismissed. They don't know, should I complain loudly, or should I not complain? Women are constantly trying to work their emotions into getting the right care. And I think when you have an advocate there, a spouse, a friend, a family member that says, she doesn't usually act like this, or I know that that she has anxiety, or I know that she has these issues, but this is different, and just that sort of little bit of help can be really important. Tell them your motives. I just want to have pain relief. I just want an answer. I'm here because someone told me I need a CAT scan. Be really open, so that way you at least that physician can address your needs. Ask lots of questions. This, I think, is key to also making change. If you go to your primary care doctor and your primary care doctor says, here's this new drug, ask them, was this studied in women? Should I take a different dose? Is there something I should know because I'm a woman in relation to the side effects or my menstrual cycle? And that doctor may not know, but it's an interesting question. And what are they going to do? They'd probably be prompted to look that up, so to give you an educated response. And so now you just sort of pass that knowledge on to yet one more domino. And so I feel like we should feel empowered to really be involved in our own medical care. And I wanted to make sure I stopped in time because I love questions, and I'd love to know, is this something new that you've heard? Is there any other thoughts or comments? I'm open to it all.
Alyson, thank you so much for this really absolutely interesting presentation. I like it very much. So I think we do one thing. We will send an email out with to your website where you also can buy this book, which I think is really interesting. And then I have seen a lot of questions. For me, of course, I just made some notes, like I go to female doctors only in the future. Yeah, that obviously is because you see as a man, if men are on driver's seat, women are in danger. And I think there is one question already in the chat, and I think it was Morenke, is this right? Morinike, would you take over and just like raise your question, please? Okay, she seems not to be there.
Yes. Yeah, so Morinika's question, Alyson, she asked, is there a certain level of hormones that a transgender person needs to attain in order to be prescribed medicines at a dose suitable for the gender they are switching to?
It's a fantastic question, and there's so little data out there that I've seen two papers, the one I showed and another one, and both of them looked at the timing of how long they were on the gender affirming hormones, not necessarily the dose. So I think over time, it starts to change your function because, the testosterone or the estrogen is acting on all the receptors in your body. And so, but of course, these are things that we're just trying to study women, never mind the whole spectrum of all of this unique stuff that's happening now, which is very exciting. But I think it's a very black box.
Thank you. Petronella says that she has a couple questions. Petronella, you want to take over?
Yeah, thank you. Alyson, thank you so much for this. As always, super inspired by the insights, and great to have you here in Switzerland as well. Two questions, actually three from my side, but one related to grants and investments focused on sex and gender-centric medicine. Where do you see that going? I've been attending over the last, couple of years, many, forums with scientists and so on, and more or less the conclusion is the same. The decision makers are men, white men, and when women scientists file in for grants or something, they get rejected because they do not see the purpose of the research that they want to further down. What are your thoughts on that? And then I have the other two questions.
Petronella, it's nice to see you. And Petronella and I work together on Core DeFio, which she says it so much better than I do. And she knows all of this already, so I'm surprised she has questions. But that's a really good one. It's a challenging one because it's where the thing that we can say is we have to advocate for women to be in those positions of power. So I feel like that's really the only surefire way to make sure. I know that femtech companies have difficulty trying to get investors because they're used to giving their investments to their buddies, their men. And so this really does just trickle all along the process, which is, I think, is what's making it take so long for us to gain real good traction on this. So I think that in order to make this change possible, it's appealing to someone enough to have a regulation. So having something like the NIH say that you must include this in your grant writing, that's been huge. Of course, you can do studies without NIH funding, but it leads us to start. So I think wherever your sphere of influence is, if you are on a board for an institutional review board, if you're on a venture capital committee, wherever it is that you have any sort of influence, to really make sure that this is high on on everybody's mind, because you're right, it's one of the more challenging pieces.
Mm-hmm. Thank you. The second question relates to women advocated for themselves. I love what you say that in your book. I see it everywhere. That's what we're trying to do also with God. If you empower women to advocate for their own health and the one of the loved ones. Now, last week, if I may share this incident or this story, but it's been a bit of a big shock for me, is I met this young woman, her mid-30s, actually with a doctorate, PhD in archaeology, highly educated, everything. We exchanged thoughts. What do you do? What do you do? Great things. And then she said, now that you make me think, actually 3 months ago, my aunt died of a heart attack. My mother has heart attack. All the women in my family, they have a heart disease or something like that. And yeah, and I was born with a congenital defect. I was like, what are you doing about it? This is really insane. She said, nothing. I don't even want to know about it. Yes, I was born with this, but I don't want to go to the doctor. And hey, if it happens, it happens. Now, this is a woman with a PhD talking in this manner. I was really shocked. I don't know, my reaction was quite obvious. I don't know. We're talking about, socio-demographic differences, but when you hear this kind of insight from a highly educated woman, what would you do? How can we take women on board? How can we make sure that women really advocate for themselves? Because I find it quite unacceptable.
I think that really bringing it home, creating the aha moment for that woman. So in her mind, she feels as though there's karma involved there, or if it's going to happen, it's going to happen. But I think empowering her to see this as bias, as gaps in our understanding of health. I think that alone, even from my healthy friends and colleagues, tends to make them feel as though that's an important thing to advocate for. So it's hard to change how someone feels about their own health. But I think if you relate it to the society, or you relate it to their loved ones, so many men I speak with say, oh, they're interested in this because they have daughters. And I think that's fine if that makes you interested in it. But I think there's a larger issue here, which is, we have a moral obligation to really study and understand both sexes. So I would just, use, there's lots of different ways that people might feel that, oh, that's the reason that I would get on board. And so just try different discussion points.
Thank you. I'll do that next time.
Thank you so much, Alyson. We've got another question from Urte.
Yeah, thank you so much for a great talk. This question kind of follows from the previous one a little bit, namely, what do you think about the potential risks involved in this kind of approach? So namely, there is some research showing that in some areas, the problem that some people are facing is actually overtreatment, particularly with procedures that may have some, that may have some negative side effects, and they're also expensive, and you have people pushing for them, sometimes without it being absolutely obvious that they need them. It's sometimes safer for the doctor just to sort of grant the request rather than deal with the patient being unhappy that they're not being prescribed or given something that they're asking for. So I was wondering what you think about that, particularly in light of overtreatment for some patients resulting in undertreatment for some other populations of patients because of how the healthcare system is set up. Thank you.
Yeah, I see that all the time. So like my patient example, if she was told it's not her heart, so go see the gastroenterologist, and then they'll go see the rheumatologist, and then go see the cardiologist, the psychiatrist. And what's going to happen is, again, she's going to be prescribed lots of medications, lots of testing. And so what I find very helpful is when patients have a record, because they come in, my electronic medical record may not be, may not sync with all the other hospitals. So I'm going to look and I can only see what's in there. But if you have a record, or you take a picture of something and you say that, look, I had a CAT scan here, I had an upper endoscopy here, this procedure, I had this surgery, then I can have an informed conversation with you and say, oh, you had that CAT scan, but that was 5 years ago, and so what can happen then? Or that was 5 days ago, we don't need to repeat it now. Or at least having some sort of informed conversation. I think it's unfortunate, but that we need to sort of take that onus on ourselves. But I feel as though that will help the conversation, and then being open and honest. Sometimes I see someone who has been through, they have chronic abdominal pain, and they've had, their appendix removed, their uterus removed, their gallbladder removed, and I just sit there and say, what can I do for you today? And sometimes it's just listening and really understanding the point of view, or sometimes it's, wanting some pain, or just wanting to be heard. So I think, being very upfront, doing your own research and keeping track of your own, health history is is important.
Hello, Alyson. Thank you very much. I did pick your answer to my first question. So my other question is that since there's such a low inclusion of women in medicine design, how much consideration do you think is being made for the inclusion of race as well as gender? And is it safe to say that women of color are more at risk of having even more dangerous side effects from medication? And just as a side question, where can we find the links to the studies you showed in your slides? Thank you.
Okay, great. No, thank you for that question. And the answer is yes, that women of color do worse than women who aren't of color. So if we look at cardiovascular disease and we say between men and women, women do worse. And then we just look at all the women and we say, oh, amongst all the women of color do worse. So absolutely, I think that it's a compounding effect. What are the confounding effects? So we look at something like race, and race is a social cultural variable. It's something that is sometimes visible, sometimes not, just like sexual orientation or disability. And if the more cards you have of being a minority, the more boxes you check, the worse off that you are. And when you look at blood pressure and stroke risk in Black men versus white men, the Black men are much more likely to have stroke, much more likely to do worse. So it's definitely an issue. And so I put that on, like, these are the social cultural norms that we have to sort of take into account as well. In fact, I was just looking at a couple other studies, one yesterday about really robust study that showed that these Black men were randomized to a white male doctor or a Black male doctor. And they found that when they were randomized to a Black male doctor, that they were more likely to want more preventive medicines and to get their blood pressure checked and to get their flu shot, because there's this communication that can occur when you look like someone. The same thing has been shown in hospitalist data and Medicare data, where women who were treated by a woman physician had better outcomes, had better, morbidity and mortality were lower. And they hypothesized it's because that if you are a woman and you have a woman doctor, they're more likely to communicate and in the same way that they feel so resonate. So if you have someone that looks like you and can communicate like you, you're more likely to do what they say. You're more likely to take the medication, or you're more likely to follow up. Or so I think that some of this data is really quite interesting. Even with surgery, it's interesting. But I think the more of the minority boxes you check, the worse off you are in our medical system worldwide, hands down.
Thank you so much for your answers, Alyson. We've got another question from Dora.
Hi. So thank you very much for this talk. It was really inspiring. And just looking at the grand scheme of things, so I have more of a question of resource allocation, because after listening to your talk, and also, so I am a scientist myself, pharmacist and neuroscientist, and I have the feeling that we are dealing maybe still more with the problem of awareness. So allocating resources towards awareness rather than, of course, resources that need to go into the research itself. But I feel like there's this big discrepancy, as also Petronella mentioned, this example, that even females ourselves are not willing to be part of it, or to recognize this or acknowledge this. And then to me, it seems like, because I'm wondering what I can do myself, right? Because I'm already a scientist and I'm trying to do things, but I'm still just one person. and how much resource then would go still into awareness, or how do you see this in the near future?
I'm really relying upon women, and it's probably not fair, but if we look at history and we look at the feminist movements, in the very beginning, giving us the right to vote, having us, our bodies ourselves, reclaiming our reproductive health, that you don't think of one person. I mean, there are some people that stand out, but when women come together and make enough noise loud enough, when one woman screams, she's considered hysterical, right? So that's why women have this really hard time of figuring out how this, what's keeping their emotion in check. What's the best way for me to, and they shouldn't be thinking of that. You shouldn't even be thinking about that. But then you look at something like the Me Too movement. We have vilified these single women that have come out, we being society, social media, if they come out against something. But when the world sort of came out and women came out in numbers, I thought, oh my God, the Me Too movement, this is it. We're fixing it. We have made loud enough noise. And then we start to go back to our lives and things start to become, common again. And I think without having continued sort of grassroots, continued movements to just push it further, and the way to make it last, I think, is to have women in power. And so, I appreciate how challenging this is. And, but I think every one of us can make some difference. Just if Petronella talked to that woman and made her realize that this is not just about her, or having you understand, ask your doctor about your understandings, and I think that each one it's what we've got. It's what we've got, and we just have to. We can't not do it. I feel like this is the kind of information that you can't unknow. Like if I show a researcher that these drugs have two different concentrations in a man versus a woman, you can't just say, to me, that's mind blowing. That means like we should look at it every single time. So whatever, you can do to have some sort of shock or enrage or aha moment of like, I didn't realize that was so important. We all, could have some effect, and it's slower than I'd like, but I do feel as though it's inevitable. From when I started this many years ago, I think just the science is showing that it's exponential and it's inevitable. We just have to break through the cultural barriers to actually study more than men.
Okay, thank you very much.
Thank you.
Thank you so much, Alyson. We are coming up to the end of our session. That was extremely informative, and I know there are a lot of burning questions that people still want answered. I'd encourage you all, if you're not members of Role Model Rebels yet, to sign up, rolemodelrebels.com. You can chat to our role models such as Alyson via the site. So you can send her a message, and if you have any follow-up questions, do that. We have shared Alyson's website in the chat, and it's on her slide here. So if you want to check that out, please do. Alyson, thank you so much for your time. This is an incredibly important topic. I think everyone here learned so much. This session has been recorded, and if you're a member of Role Model Rebels, you can rewatch this session as well as see the slides from Alyson's presentation in the Members Hub. It's free to join right now, so just sign up and you can follow up by there. Thank you again, Alyson, and have a fab day because you're stateside. So thank you so much, and we look forward to seeing you again soon. Bye, everyone. Thanks for joining us.
Thank you. Thank you for the opportunity.
Alyson. Thank you so much.
My pleasure.